All right, so let's look at those chemoreceptors a little closer. So we have both central and peripheral chemoreceptors that are going to detect changes in either blood or in cerebrospinal fluid. There we go. So let's look at the central chemoreceptors. They're found within your cerebrospinal fluid, and they detect changes in pH associated with changes in the partial pressure of carbon dioxide. So as partial pressure of carbon dioxide increases, the pH of our system decreases. And you don't want your pH to drop below 7.35 or you'll be in acidosis. And so any change in pH sends a signal to the medullary respiratory center, and this stimulates your breathing rate to increase. And that will blow off that carbon dioxide, bringing your pH back up to where it's supposed to be. We also have peripheral chemoreceptors that are found within our carotid artery and in the aorta. And these detect changes in the partial pressure of carbon dioxide directly. So not so much the pH change associated with it, but just the amount of carbon dioxide. And they also can detect changes in the partial pressure of oxygen. But the change in the partial pressure of oxygen typically just makes the chemoreceptors for carbon dioxide to become more sensitive. And so the increase in carbon dioxide actually causes, again, our medullary region to stimulate faster breathing so we can blow off that carbon dioxide. Now, people with COPD aren't able to blow off the carbon dioxide. And so that leads them to having oxygen become the driving force for breathing, and that is termed your hypoxic drive. So if you have like severe emphysema, you can't get rid of the carbon dioxide, so carbon dioxide receptors become less sensitive to the partial pressure of carbon dioxide. So this causes your decrease in oxygen to be the driving force for breathing. And so if you add oxygen to the system, the driving force drops and you stop breathing. So that's kind of what this cartoon over here is. Here you have a COPD-er, so someone with COPD. They have a low oxygen level. So you can choose to let them code from hypoxia, they don't have enough oxygen, or give them oxygen and risk apnea where they stop breathing altogether. And so that's a really major problem with people with COPD. Here's one of those animations. I'm not going to go through it with you. I've been through this a few times, so all you have to do is click on it from your PowerPoint, and you can actually go in and go through the regulation of pulmonary ventilation, okay? So let's look at sleep apnea, or what apnea is. Apnea then is just the absence of breathing. You stop breathing. Eupnea is breathing. And so we can voluntarily stop breathing if we hold our breath or when we're swallowing, but it can also be induced by drugs or by different disorders. And one of the more common forms of apnea that is becoming very common is called sleep apnea. So this is cessation of breathing during sleep. And so a very common reason for sleep apnea is an obstruction. So obstructive sleep apnea is probably the most common form of sleep apnea. And so here you have that soft palate with the uvula. And we have these muscles here. So when you sleep, your tongue relaxes, You have the soft palate here with the uvula. It relaxes. Everything relaxes, and it can actually block your breathing passageway. And that leads you to have these periods where you're not breathing, and then all of a sudden you will start breathing again. Often associated with a very loud snort. So people with sleep apnea oftentimes snore. So you might, and they usually don't know they have sleep apnea. It's the person that is by them that knows that they have sleep apnea, or that can actually determine it. So if you are a heavy snorer, if you fall asleep super fast, like within the first 2 minutes of laying down, you fall asleep. If you wake up several times a night, if you are tired throughout the day, those are all symptoms of sleep apnea. But you may not even realize you're tired because you may be so used to not getting much sleep that you don't know you're tired until you have been diagnosed and you get a treatment for it, which the most common treatment is a CPAP machine. So I know a lot about this because I actually have obstructive sleep apnea. So every night I wear a CPAP machine and I sleep really well now. But when I wasn't wearing one, neither me nor my husband could sleep effectively. So I didn't have as much problem, I didn't think, until I realized I did. But I would fall asleep within a minute or so of hitting the pillow, and I snored, and but basically it would be whatever, normal snoring, and then all of a sudden I would stop breathing, and then when I started again, I'd be like, and it sounded like someone was trying to kill you, is what my husband would say, and then I'd start breathing again. So very, very, pretty sounding. We went to the doctor together because I really couldn't answer a lot of the questions, so he answered them because he was the one who could answer them, and I ended up having a sleep test, and I woke up 36 times an hour. So I was like, what? And that's considered moderate sleep apnea. There are people that will wake up every single hour over 70 times. And they won't know they're waking up because they wake up and they fall right back asleep. And so 70 times, that's more than one time a minute that you stop breathing. Every time you stop breathing, your body has to wake you up so that you can start breathing again. And so I was doing it about one every 2 minutes, so 34 times or 35 times, something like that. And that was considered a moderate sleep apnea. So I sleep much better now, which is good. And again, there's a video here if you'd like to watch it. It just talks about what sleep apnea is. So now let's look at airflow. So air is moving into our lungs associated with two major factors. Pressure gradient, so air always moves down its pressure gradient, and resistance, so anything that is keeping the air from moving down that pressure gradient. So these are in opposition of each other. And so we could actually figure out our airflow by taking the pressure gradient divided by the resistance. If you have a great resistance, then airflow decreases. If you have less resistance, airflow will increase. And of course, if you have a high pressure gradient, airflow increases. Lower pressure gradient, airflow slows. So resistance, in a nutshell, is anything that makes airflow harder to occur. So if you have less elasticity in your chest wall, then you're going to have an increased resistance. If you have a change in your bronchial diameter, that's going to increase resistance. if you have increased surface tension in the alveoli, that causes the alveolar sacs to collapse, that increases resistance. And that actually leads us to a disorder called respiratory distress syndrome. ARD is typically associated with premature babies, and it can lead to the inability for the baby to use their lungs, and they could actually die. So inability of gas exchange. So typical treatment for a premature baby, they're going to, one of the major reasons for this is because they don't have as much pulmonary surfactant. Surfactant is what keeps our alveoli from collapsing. And so they will be injected with a pseudosurfactant, so basically a pharmaceutical surfactant that allows the lungs to work without, or that allows the lungs to, or the alveoli to stay open even though their own cells aren't producing the surfactant yet. They also can keep, or they can also put the child on a CPAP machine, or they can intubate them and breathe for them until their lungs are able to work on their own. So the next part is about alveolar gas exchange and systemic gas exchange. I'm going to stop on this video because I've already talked for 11 minutes, and then we'll get into the next video with gas exchange, okay? Bye.